today. This is an absolutely incredible turnout. We are excited. A couple of announcements. If you need continuing education credit, I said that 3 times, and did not sign up on the CEU list, you need to make sure and get signed up, sign your name, because that's the list we have to send back to Texas Counseling Association for the documentation in case the LPC board ever questions who is actually here. So, and then at the conclusion today, we'll be passing out certificates for you to take home with you to put into your personal file. So if you get off, like I did one time, you can prove to them you actually did what you said you did. The other thing is, if you did not get a little blue drawing ticket, raise your hand and we'll get you a blue ticket, because we're giving away 2 door prizes today. About halfway through, we're giving a gift card to Walmart, and our last drawing today will be for a PCA membership for next year. So, if you didn't get your little blue drawing ticket, raise your hand and I'll have somebody bring you a blue ticket. Oh, good. Everybody got one. Also, on the table out front, you will find a copy of our brand new PCA newsletter. And hopefully within the next week to 10 days, if you are on our last email listserv, you will be receiving a copy of that on your email. It is incredible. So if you're not getting our blast emails telling you about the meetings and that sort of thing, be sure to put your email address out front next to your name, and Sarah will add your name to her list so that you'll get all the notifications about meetings and the newsletter and all those sorts of things, because we're doing some preliminary planning for next year, and I can tell you we're going to have some incredible programs. So get your email address out there so you can sign up for that. Our first speaker today is Valerie Cox. She is a counselor at South Plains College Reese campus and is a licensed clinical social worker. Did I say that?
Yes.
And she will be speaking to us on suicide prevention. And I told her she won't be anything about who she is, she can do it. So let me introduce to you Valerie Cox.
Thank you. Thank you. Hello, I hope everybody can hear me out there. Great. Today I'm going to be talking about suicide prevention. And I've been studying suicide prevention for quite some time and looking at it from different avenues. And so the difficult part for me today was to decide what to tell you and what to leave out. And so today is not going to be about suicide assessment. So what I'm talking about today is going to be about some of the trends that I've found among people who are suicidal or complete suicide. So first, I'm going to start with some statistics. Oops. Maybe. Okay. I have to hit the right button. No, that's not it. Okay. There we go. Okay. So I wanted to start out with just a little bit of statistics, because you need to be aware of the numbers that we're talking about. From 1999 to 2010, suicide rates in the United States increased by 20%, which is very significant. But you can also see these numbers go back from 1993 all the way to 2010. And so you saw a gradual dip, and then it came back up. So what was going on in 2008, 2009? Financial crisis, right? The housing? War? So there were quite a few factors that came into play that created an increase in suicides. And so I didn't get a chance to look up what was going on in 93, 94, but from my memory, I believe we were in some type of recession at that point. Does anybody remember? It's been a while since I didn't remember back that well. So I think there might have been a recession going on around in those early 90s, so as well. Okay. So suicides in the United States. Suicide is the 10th leading cause of death in the United States. So this accounts for 36,000 or more deaths each year just from suicide. So in the year 2010, 38,364 people died by suicide. That accounts to about 105 people per day. So, as some from the Vet Center could tell you, 18 to 22 of those are veterans. Okay, and they did some research on people who had completed suicide and what was in their bodies, they had been taking. 33% of them tested positive for alcohol. 23% tested positive for antidepressants. And 20.8% tested positive for opiates, including heroin and prescription painkillers. So, is the problem antidepressants? Yes, no? Guesses? Well, it may be that they were using antidepressants and something else, right? And sometimes people, as we know, they take their antidepressants sometimes, and not all of the time. And we also know that when people are having trouble with their antidepressants, they have a resistance to going back to their doctors to tell them this is not working and we need to try something else, right? So there's several factors that come into play. Gender and suicide rates. For men, the rates of suicide is 4 times higher. Why do you think that is? What they use, exactly. What they use to kill themselves. Because men are more likely to use a firearm to commit suicide, while women are more likely to die by poisoning. Women are more likely to take pills. So men account for 79% of all suicides, and 56% of all suicides, they use a firearm, okay? Even though we will find women who do use firearms, and that number increases for, say, women that are veterans, who they have more access to firearms. Okay, I want to talk a little bit about the human brain. So there's 3 things that your brain does out of a lot of the things your brain does. So about our memory and where we are, the brain reconstructs your past, it constructs the present, and it predicts the future. So these are automatic functions of your brain. When our brain is predicting the future, what we are thinking and what we visualize for our future, what we anticipate, what we expect, what we hope for, what we wish for, what we pray for. So we may have plans. Most of us probably have goals, right? And see kind of where we're going to be in a few years, next week, a month from now, a couple of years from now. We're planning out retirement. So our brain helps us to start thinking through how to get there, from where you are to where you want to be. Now, for a suicidal person, they may be thinking, there is no future, only death, despair, and so your brain is not going to work towards getting you into a better place in your life. So your brain can help you get to the goal that you are seeking, which might be suicide. So then their brain starts working, they start coming up with ideas that most of us wouldn't even come to our minds because we're not envisioning that future. So there is an inner conflict with suicide. Part of you wants to die, part of you wants to live. And the reason they know that is from people who have taken things like a chemical substance to commit suicide. The problem with chemical substances is that often the person doesn't die right away. They may die in an emergency room. And when they talk to these people who have tried to commit suicide and are going to die, there's no backing out of that damage because they are going to die, they will tell people that I want to live. I really want to live. I don't really want to die. So, also, your body is designed to live, and keep you alive. So when someone cuts themselves, so a lot of people who might try to commit suicide through cutting, your body is working against you in that the blood clots begin to form immediately when you have a cut. So some people who are trying to cut to commit suicide, their bodies don't allow them to die because your body automatically works towards stopping that and healing that, right? So you have an oppositional force at work. So opposing forces, your desire to die, your desire to live, your body's desire to continue to live. So your body's job is to keep you living, right? Breathing in and out. We don't think about breathing in and out. We don't think about closing our eyes and opening our eyes. We don't think about a lot of things. We don't think about digesting our food, right? Our body does things automatically. And so you're trying to override some of those automatic processes that are designed to keep you alive. So you're overriding the system of your body. And so people say suicide is the easy way out. You may have heard someone say it's a cowardly way, the person was weak, things like that. But that's actually not true. Because to override the system of your body is very difficult. It's very difficult to go through with a suicide. So you could call them weak, but you could also say they actually had the strength to do it, even though it's a strength to do something negative. So suicide is not the easy way out of life. So when the other part of our brain that I talked about earlier was reconstructing the past. So we don't do a really good job of this. Some people do better than others. If you think about what you ate for lunch yesterday, you might not remember. Where did you go out to eat the last time you went? Tell me what happened when you were 2. Do you know everything that happened? What we get are pieces, like pieces of puzzles, kind of patchwork, and our brain fills in all those missing pieces from our memories and through our imagination. So once I read a book about the memory, and they said, for anybody who writes about their life, it should actually be called fiction. Because it didn't exactly happen exactly the way we remember it today. You may get the gist of what has gone on, but probably you are missing a lot of the details. Creating the present. This is the third thing the brain does. So we're creating who we are now by our thoughts and our belief systems. So people who are suicidal, I would say, assume that they have faulty belief systems. So we are carrying around events that happened to us that we don't have a specific, vivid, detailed, accurate memory of. So you think, okay, when this person was 8 years old, this is what happened. And so you are looking at an adult who is interpreting the event, not as an adult often, is what we see in our clients, but as the 8-year-old child. And so they carry that original belief system and the thoughts that came out of that with them into their adulthood. So what I ask people is, when did you begin to believe that? Usually it's because it went somewhere back in time when they were a child. How old were you when you believed that? How knowledgeable were you when you believed that? Did you have your college education back then? Did you have a lot of insight back then? And if you can work with them, you can make them realize that that is an 8-year-old's belief, and it's time to revise it as an adult. It doesn't fit anymore. So we form our belief systems based on faulty interpretations due to age and maturity when the event or events occurred. For example, a child may remember being berated by their father. That's true, right? That's a true event. But where the faulty belief system comes in is, I caused it. I made this happen to me. I made my father so angry that he berated me in front of all of my friends, and humiliated me. I created this. So that's where the faulty belief systems come in. So when we're constructing the present with faulty belief systems, we have distorted views of who we are, who other people are, such as someone who says, well, that person looked at me wrong. I must have really done something wrong. I must have made them angry. I wonder what's going on. And they tell themselves all kinds of stories because someone looked at them the wrong way. So I remember an example. I was working at Joe Arrington Cancer Center, and a young doctor, he went down the hall past me, and I said hello, and all I got was silence. And so I started telling myself, well, who does he think he is? I'm just a peon, I'm just a social worker, he thinks he's so all that. Well, that's the story I told myself. There can be a lot of stories out there to explain what happened. He may be so deep in thought that he didn't even realize or pay attention to who's there or what they said. So there's a lot of different realities. There's a lot of different stories. But we tend as human beings to make up stories and make our story the true story. Mine is the true version of what that was about. So if you imagine your belief systems as a foundation, this is what I'll explain to my students. Your belief system is your foundation. If you have a solid foundation, you're going to have good structure in your life. But if in your foundation are belief systems such as, I'm never good enough, or I hate myself, or no one likes me, and no one accepts me, and on and on and on. So those are cracks in their foundation. And so what's going to come out of that are faulty thoughts, which create that distorted view of the present. So constructing the present, past forward. So when we have events that happen in the past, which suicidal people often have a lot of stuff in their backgrounds, a lot of history. So the thoughts, the emotions, and the sensations that we experienced in the past become triggered in the present. I've had students tell me in my office that that professor just got in my face and told me this, that, and the other, and they are so mean. And I realized very quickly that something was triggered for that student. You know, think of another time when you felt this way in the past. And chances are there's something, a parent or an authority figure, that they remember as being abusive, and then all of that is brought up. And so the reaction is not the appropriate one in the moment, but they cannot see that. And then the thoughts that are triggered or emerge from your belief system, which we've assumed is faulty in people who are suicidal, those impact, those thoughts, and then our choices. Of course, I don't have to explain to you that thoughts create emotions, and emotions create behavior, right? We all get that. But because of that cracks in that foundation of their belief systems, that is impacting every one of their choices that they make, which are going to be, if you have a poor foundation, are going to be wrong choices, bad choices, choices with consequences that bring them more pain into their lives. So, and that reinforces that original belief system. There, for example, I had a student in my office, and he said, I need to get through college because the only kind of jobs I can get is a dishwasher. And I said, what do you mean you can only get a job as a dishwasher? He said, well, I'm a Mexican. And when I go into work, they put me to work as a dishwasher. And I said, okay, let's talk about that for a moment. And so as we talked, what really came out was that he didn't like to talk to other people. He didn't want to be around other people. He didn't like gossip. He didn't like politics. He didn't like, all the stuff that could go on among coworkers. And so he would go into an employer and say, I need a job where I'm not around anybody and I'm by myself. And so they said, okay, I guess we could put you as a dishwasher. Okay? So you can see where that faulty belief system came in. It had nothing to do with the fact that he was Hispanic. It had to do with, I need a job in this restaurant where no one talks to me and I don't talk to anybody else. And that's the only job that fits the bill, right? Right, adverse childhood experiences. So many people who have experienced adverse childhood experiences have been told things about themselves that were negative and often untrue. So these negative and untrue things become part of their own belief system. So they accept that as true, and then they carry that around with them into their adulthoods. So with adverse childhood experiences, I've just done a little bit of research on it recently, but it also creates other problems, such as suicide, eating disorders, promiscuity, self-harm, drug abuse, right? We see these people, right? Okay. And also all that negative emotional stuff that they're carrying around creates things like heart disease or pulmonary disease, liver disease, all kinds of things. So they did a study many years ago and connected adverse childhood experiences with severe physical ailments. I heard the other day that people who had a very troubled past often and have the medical conditions that come up as a result often live 25 years less than the general population. So even if they don't commit suicide, they're taking many years off of their lives in their behavior. And another statistic, a man with a high level of adverse childhood experiences, it said a score of 6, So that's out of the scoring system for that. Has a 4,600% increase in the likelihood of later becoming an IV drug user. So that's major, major impact. So we have a downward spiral of thoughts when you've had lots of things happen, you've just reinforced your belief systems because of your choices and their consequences. So when people are suicidal, they're having these looping negative thoughts that kind of go around and around and around, are those self-statements. And all those negative thoughts, they just build on more, right? And they just get worse. And so it creates that spiral, downward spiral of despair and hopelessness, which is what we see in what? Mental illness. Hopelessness. Depression. Exactly, depression. So here's another problem. I may be getting a little bit ahead of myself, but if this is your client, if they go to their medical doctor will say, here, take this pill, right? And hopefully that will help. Hopefully that's going to take care of the problem, okay? So that is just one little piece of the problem. Unfortunately, a lot of the people we see, that's all they are getting, especially when they go to their medical doctors. So I think there's probably a handful out there that say, here's a referral for some counseling, but most of them are going to prescribe something for those symptoms. So also people have unhealthy emotional expressions. So people who are suicidal often don't have the skills to express strong emotions. So instead, they stuff them, hide them, avoid them, or choose something else. So instead of sadness, what are they going to choose? Anybody know? Anger. Exactly. Because anger is a more acceptable response. And the world gives us lots of opportunities to express our anger and hostility. Right? The line, the car that wouldn't let you in. I mean, there's all kinds of things that they can let that emotion out. But that's really just a cover for that loss, that deep loss, and they don't want to experience that. So I had a student in my office recently. Her friend had committed suicide a few weeks prior, and this student did not know how to express emotion. So she didn't cry at the funeral, hasn't shed a tear. You know, she's been real obsessed about the death and all of this. So finally, I was able to have her see. I said, how did your friend, y'all were close, when you asked her how she was doing, what did she say? I'm fine. So she did not express her emotions. She did not say the things that were going on. And so I was able to tell the person in front of me, you're doing the same thing. You are stuffing your emotions. You are not talking about your problems because she hadn't been up to that point. And so you can see where this leads. So now she told me last week, she goes, there's another friend, and I'm really concerned about her because she's not expressing any emotion. She's not talking about it, and I'm really worried about her. So I thought, that's awesome. That's awesome, right? So maybe we can stop that cycle, that contagion, which is true. Other risk factors for suicide. Isolation. They often feel unworthy of connection. If you knew everything about my past, you would hate me, reject me, not talk to me, right? And so they also have poor coping skills, alcohol and drug abuse, a history of suicidal behavior, and a family history of suicidal behavior. So if it was okay for my dad, it's okay for me. You know, just like the parents that smoke, the children are more likely to smoke. If the parent commits suicide, the children have an increased risk for suicide for themselves. Other risk factors include lack of conflict management skills. When things go wrong, they have no skills of how to handle that. So they may just come in and start screaming. Legal problems, relationship problems and breaks in those relationships, inability to regulate their emotions, and a lack of communication skills, right? They're not good at that. So here are some assumptions about suicide. And here's this quote from a philosopher that said, there is but one true philosophical problem, and that is suicide. So the first assumption is suicide is the problem. The second assumption, there are few solutions to the problem, if any. Unless you are a counselor, there really isn't anything you can do to prevent suicide. And then fourthly, suicide is inevitable. You can't stop someone if they want to die. Have you heard people say that? If they want to die, they're just going to die. And there is nothing you can do about it. I've heard people say that. Those are assumptions. So the facts are, suicide is not the problem. Suicide is a perceived solution to whatever problem or problems they are having in their lives. It's a solution to them. I have these problems. I don't know what to do. This is a way out. The problems that result in suicidal behavior are varied, right, as we can see with the trends. So, and the problems that result in suicidal behavior cut across age, race, socioeconomic status. So, children, I recently went to a workshop, and it was a woman that worked with children, and I asked her, how young of a suicidal patient have you seen? And I was really surprised that she said 4 years old. 4 years old. Elderly people, men over the age of 75 years old are the highest at risk. So they're used to working. And when they are losing those abilities, and they can't do what they did before, they didn't really make a lot of friends and connections, right? And so that may be a perceived solution. So with the current solutions for suicide, we are trying to stay one step ahead of the suicidal people out there. So we try to identify them and get them help. So the solution, what is the solution? So there's not one, there's multiple. Because if the problems are multiple, the problems are varied, then we have to have multiple varied solutions. Here are some current solutions that are very good. They're very good, and I highly recommend them. QPR. I'm trained as a QPR instructor. These are called Gatekeeper Programs. The QPR and Assist are two of the Gatekeeper Programs. And what that means is we're going to go through and we're going to train everybody in your place of employment how to recognize warning signs and risk factors. So that's the person that's at the front desk. That's not the counselor. That's the person that's taking out the trash. So for us at South Plains College, that's the admissions and records folks, the financial aid folks, all these other departments that don't have counseling skills, and you don't have to. That's what I tell them. The good news is you don't have to be a counselor, because people who are not counselors don't want to be, right? So they learn how to get help where to get help and how to get them to that help that they need. And then there's crisis lines. Again, are very important when someone's feeling suicidal. They have a 1-800 number to call. And in your packet of your web resources, you have a list. I have 3 pages of web resources. And in here is our links for the QPR program, the ASSIST program, and for the crisis line phone numbers. Here are some other current solutions. Emergency rooms. Emergency rooms are burdened with people who have mental illness and are suffering from suicide ideation or attempts. Psychiatrists are also a solution. Counselors and psychologists. Mental health facilities. Jails, prisons. How often do we see someone who doesn't get help until they're in prison? That's the first time they were able to get the help that they needed. So some of the underlying needs of suicidal people. The emotional regulation skills. So these are things I want you to pay particular attention to as counselors, so that when you're thinking about your clients, think about, these are the things I need to be teaching some of them. They don't know these things. So emotional regulation skills, okay? Instead of going 0 to 90 as a reaction, how to regulate and stay balanced and within a normal, halfway normal range of emotional expression. They need communication skills. Everybody needs good communication skills. Even we do sometimes, right? Conflict resolution skills. When they're not getting along with someone, what do they resort to when they get into an argument? Do they start immediately screaming? Immediately punching? Right? Putting people down? And how to replace negative thoughts, which I think we're all very good at that, right? We're all very skilled at that. And people need healthy connections. So we need to encourage people to have friends, connect with friends. If they don't have friends, they need to go to places where they could meet people. So different organizations, join a group, join a club, join a church, do something to where you're staying connected to other people. Other needs: self-esteem, self-awareness of who they are. A lot of people don't, they have a very distorted view of who they are right now. Self-care, so learning how to take care of themselves. And self-compassion. So not just nurturing others, but nurturing yourself. Okay. Nutrition and sleep solutions. So what I want you to take away from this is to think about the problem is not suicide, but that they need multiple things to help them. The stress management, the coping and problem solving, money management, parenting, treatment for substance abuse, marital counseling, exercise, and things like wellness campaigns will help. And you need to know the risk factors and the warning sign. Understand trauma and what people have experienced in their past so that you can relate to them in a very caring, appropriate way. Understand depression and always screen for suicide. I'm not going to go through the questionnaires, but I do have handouts that I will pass out on each side of the room. So you can take these. I'm going to set aside, here's a packet over here. And the links for these assessments are in your packet. Okay. Okay. And some of the obstacles we have are awareness, the access to mental health, awareness of the problem, things like poverty, and the people who need the care the most are not the ones that end up in front of us, right? They're not the ones that come to our office. So we need to teach, educate, and advocate. And always identify, assess, listen to them, and get them the help that they need. The main question to ask is, are you suicidal? Are you thinking about killing yourself? So, lastly, I want to remind you, when you're taking care of everybody else, to take care of yourself. So, manage your own stress. Take care of your relationships. Have and spend time with your friends. Go to lunch on your lunch hour and leave at 5 whenever possible. So you don't want to forget that you are important as well. And if you're not stable, then you can't help your clients. So you want to practice good nutrition and exercise. So you are the only person you've got, right? You've got one body. You don't want to wear it out early. So when you take care of yourself, you're encouraging healthy boundaries with your clients. You're encouraging that ethical behavior, empathy, and you're more positive because you're coming from a better place. And you need to be more stable, more resourced, and able to care for others more than they could care for you, right? We don't want to be on the other side and them sitting there comforting us. We're here to help them, not the other way around. So that's where I'm going to stop. I appreciate your time. And next, Dawn is going to come up and introduce our next speaker. Thank you for your time.